Welcome to this episode of the Healthcare Bridge, where we explore the vital connections shaping our healthcare landscape. Hosted by Nathan Kaufman, Managing Director of Kaufman Strategic Advisors, the Healthcare Bridge is dedicated to improving healthcare delivery by strengthening the strategic and financial performance of healthcare providers. As part of the Common Bridge family, our focus is on fostering insightful, nonpartisan conversations that drive meaningful change in the healthcare industry. We invite you to join us as we build bridges toward a healthier future. The show is available on Substack, YouTube, and your favorite podcast platforms. Search for the Common Bridge and stay connected.
This is Nate Kaufman with the Healthcare Bridge, welcoming the founder of the Common Bridge, Rich Helppie, to talk a little bit about drugs and drug costs. I'm talking about pharmacy here, Rich, just to be specific.
I needed that clarification. I appreciate it.
Any thoughts that you have initially?
Yeah, you know, our readers, listeners, and viewers on the Common Bridge, and of course the Healthcare Bridge, a very popular publication now under the banner of the Common Bridge. I should mention, Nate, your program's got off to a phenomenal start, and I had no doubt there's nobody more knowledgeable about healthcare that I know than you, and I know hundreds of people in healthcare, but people don't understand why the cost of drugs in the United States are so expensive. And, you know, in the Biden administration for the Inflation Reduction Act, they did try to cap some of the expenses in Medicare at $2,000 a person. They tried to put a price controls on certain drugs. They promptly got sued. Our taxpayers got sued, you and I, by the people that make the drugs, saying it's unconstitutional for them to be denied the ability to price gouge, which is kind of the essence of their lawsuits. But this recent week, President Trump sent a letter to 17 of the big pharma companies and said, we're going to use every tool in our arsenal to give us those that get Medicaid and presumably Medicare, most favored nation pricing. I don't know if you've looked into this at all, but what's your take on this?
So, you know, the United States of America is the largest health insurance company in the world, and the only one with its own Navy, by the way. And so even though it is the largest health insurance company in the world, it can't buy drugs in bulk, which is just baffling. We are one of the few countries where it's basically individual negotiations. It makes absolutely no sense. And what the drug companies all say, the pharmaceutical manufacturers all say as well, we needed to fund research. Well, have you watched the news programs at all? Every other commercial is about some drug for something. And I mean, these aren't like common illnesses. These are like weird eye things that are going on. And so the point is, it's not just to fund research, it's to sell your products and to really invest in advertising. And as a result, who's paying for that? The consumers. And it makes no sense.
But, you know, I've seen some of those ads, and, you know, one of them, there was a guy walking on the beach, like digging clams. And another one was like pulling up crab traps, and they looked really happy. And then in the evening, they were, you know, drinking wine and dancing with their wives and eating that shellfish. And I'm like, I want that disease, because I want to do that with my wife. I want to go eat good food and dance and look real happy like that. But they never got around to telling me what disease I needed for that. Although the jingle about diabetes is particularly in poor taste. But look, Nate, there are people that will say that our tax dollars go to research facilities, including universities. It's used for drug development. The drugs do cure diseases. And then when they come to market, there's no payback to the United States taxpayer. And indeed, the United States taxpayer has to pay again premium amounts in order to buy the drugs that someone in Europe or Canada or elsewhere is getting for a quarter of the price. It seems like we know who the chump at the table is here, right?
Yeah, in fact, I was at a barbecue many years ago with somebody from a pharmaceutical company that created the drug for Hep C, hepatitis C. and the drug was costing $20,000 or something like that per administration. And I asked him, well, how'd you come up with that dollar amount? And he said, well, that's probably what it would cost if you had to go in the hospital and get it cured. It wasn't based on what their cost of production was or anything like that. It's just based on how much money they can get away with. And then on top of that, if you look at drug distribution in our country, you've got the manufacturers who sell to wholesalers, who negotiate with PBMs, pharmacy benefit managers. And what we have are all of these silos that are in the drug distribution channel. And there's a saying, and the saying is, if you optimize the parts, you sub-optimize the whole. So the drug companies want to make as much money as possible. The wholesalers want to make as much money as possible. The PBMs definitely want to make as much money as possible. 80% of all drugs distributed in our country go through 3 pharmacy benefit managers, all owned by insurance companies. And so the issue becomes, we've sub-optimized the delivery of prescription drugs to people like you and me, and we have no ability to change it.
Yeah, and I remember back in the George W. Bush administration, they were looking at ways to try to do direct negotiation. And the headwind that they ran into is they said, okay, where do we negotiate? Is it at the manufacturer, the wholesaler, the retailer, at the point of sale? They couldn't figure out where to go. And this is when they spawned the Medicare Part D, which frankly I like, because Part D is a fair fight. It pits the for-profit insurers against pharma. And so if the pharma company can't get the medication to a price point that the insurer will pay, it doesn't go on the formulary. And I think one of the risks, if we go to, say, having CMS do the negotiation and they can't get to the price point, then that pharma company goes and lobbies the senator with campaign, and now we've got an inflated drug price in the formulary. And that, to me, is the risk of this going 100% into a government-run negotiation.
Well, let me give you the other side. So I have a relative who hates me bringing up the story. It's about irritable bowels. And he or she had to take this medication every day. And he was on Aetna. And the copay per month was $5 for 30 days of the medication. He or she then, their insurance company changed from Aetna to Elevance, also known as Anthem, and that $5 copay increased to $330 for the exact same drug. And that was the PBM trying to influence the profits or generate profits through what's called spread pricing of generic drugs. This person was pretty smart, no healthcare. He was an insider. And so what he did is he called Mark Cuban's place down in Dallas and said, if I send you a script, what will it cost? And Mark Cuban's place said $20 a month. And so that's where this person who lives in the Northeast is getting his pharmaceuticals, because it doesn't make any sense at all how they're priced or what the copays are. It is just based on maximizing shareholder value.
Indeed. Look, I can tell you from personal experience that we found a Canadian pharmacy and started buying things that were needed regularly for various family members from Canada because it was easier, and the doctors were only too happy to write the prescription for us to get these things for the family members from Canada. It was cheaper just to buy the entire drug from them versus it paying the copays and such. Now, the interesting thing, although these drugs were manufactured in another country, in one case, India, and then shipped into the United States, some of them that would go through the insurance system, others shipped to Canada, they were said, well, if you reimport those drugs, they're going to be dangerous. I'm like, it's the same drug from the same factory in the same country, yet it's going to be dangerous because it costs less money. It makes no sense. So one of the things in President Trump's approach to pharma is that as most favored nation, and one of the examples they used was a medication available in Europe for $40. That same medication in the United States, $290. And what the president is saying is, look, charge everybody $145. And maybe similar to NATO payments and such, Europe pays more, the United States pays less, pharmaceutical company makes the same money because it all balances out. Is that even implementable, something like that?
Well, again, we don't have the ability from at least Medicare and Medicaid, which are the largest insurers, to negotiate those kinds of rates as a single entity. So it is pretty difficult unless the law is changed in our favor, which I hope someday it will. But the differential in prices makes absolutely no sense.
Indeed. So they've talked about direct-to-patient pricing. That's another thing the president has floated, that you go buy directly from the manufacturer and that there's a posted price. I mean, that seems attractive, but I'm just wondering, again, how easy would that be if the dispensary is also the manufacturer?
Yeah, I think that there is a distribution system that is required to get the drug from the manufacturer to the patient. And the issue is there are just too many people taking pieces out before the drug gets to the patient. So I think that the idea of eliminating middle people who add no value, primarily the pharmacy benefit managers, would be a great idea and would significantly reduce the cost of drugs. It's not that the PBMs don't provide a service, it's that they're for-profit entities who have a fiduciary responsibility to their shareholders, which creates a conflict of interest with respect to what's best for the patient.
Indeed, and they've gone around what the actual pricing is with rebates that escape the scrutiny of the calculations about what the fair price is. Look, I don't know that we can solve this, although I think the best answer we've got right now, Medicare Part D, it steals some ideas from the Australian system for their national health care, which is when you're eligible, whether you need to make claims or not, you can get into the system. It's not very expensive. It's the 80-20 rule. So 80% of the people use 20% of the cost, 20% of the people create 80% of the cost. And what we need is those 80% that use 20% to be paying in. And that way there'll be enough money in the system. And under the Part D plan, if you wait because you don't take any prescription drugs and now you're prescribed some, there's a big catch-up penalty, very similar to what Australia did. That program is still running 95% subscriber satisfaction. It's still running 40% below the projected costs. And again, I think it's a fair fight because the big pharma's got to negotiate with big insurance. And, if it was up to me, if everybody in the country would be eligible for Part D.
Think about this. We have this giant insurance company at the federal level that consumes 26% of our federal budget. At the state level, it consumes over 30% of the state budget. And every 4 years, we change the CEO of these giant insurance companies. And every 2 years, in some cases, like with the House, we change board members. So how can you have a consistent healthcare policy and deliver the optimal delivery system, if you will, when you have this turnover at the executive level so frequently?
Well, you open up a great aspect to this, Nate, because of that CEO and of those board members, there's like two that understand healthcare and the mess that we're in, which is why we get crazy legislation going through. And that is why when any politician dares to touch that rail about healthcare, the rest of them grab talking points, as they've done recently. We're going to throw crippled children off of their care, and 11 million people are going to die, which was complete nonsense. But political world is not designed today to deal with the issues that are affecting Americans. And this is the most critical. But I think with you and I can do a little bit of work toward educating folks. Maybe they'll talk to people and eventually the political class will hear about it. I don't know, but I'm always an optimist.
Well, here's the situation. If you're not in the healthcare system, if you're not talking to doctors and talking to healthcare administrators and watching how care is delivered, you don't understand the nuances.
Right.
And when you don't understand the nuances and you create policy, there will be unintended consequences. And the unintended consequences of our systems are high costs, but even worse, access. Try to find a rheumatologist when you're diagnosed with arthritis. Good luck. So it's critical that you find an insider who can help you navigate through this crazy healthcare system. And I know I can speak for you that you and I are more than happy to share our knowledge with respect to the nuances of the healthcare system with anyone, especially some politicians who are heading down the wrong direction. So this is Nate Kaufman with the Healthcare Bridge, thanking Rich Helppie for participating, and have a great evening.
Thank you for joining us on this episode of the Healthcare Bridge. We hope you gained valuable insights into how strategic and financial analysis can transform healthcare delivery. Remember, building stronger connections in our healthcare system is a collective effort, and we're honored to be part of that journey with you. Be sure to subscribe and stay tuned for more conversations that aim to bridge gaps and create a healthier future for all. You can find all your Healthcare Bridge episodes at The Common Bridge on Substack, YouTube, and your favorite podcast platform.